All right. Well, I think we should go ahead and get started. I want to welcome everybody to Medicine Grand Rounds today on this first day of November. Today, I'm very excited to have a topic that many people have expressed interest in hearing more about, which is medical misinformation. Clearly, one of the real challenges, I think, of the last several years, and something that has moved to the forefront of many of our thoughts. So we have a fantastic guest who is going to speak to us about this. Dr. David Scales is a physician and medical sociologist at Weill Cornell Medicine, and he's the chief medical officer at Critica, an NGO focused on building scientific literacy. His Ph.D. dissertation examined the global governance of infectious disease, and he completed a postdoc at healthmap.org at Harvard Medical School in spatial epidemiology. He then completed a primary care internal medicine residency at Cambridge Health Alliance, and he practices as a hospitalist. His current research, however, focuses on medical communication in clinical and online settings, including understanding how to address misinformation within digital communities. His work seeks to emphasize how structural factors affect our information environments to allow misinformation to propagate and misconceptions to persist. He leverages qualitative and quantitative methods to address misinformation, training infodemiologists to build COVID-19 vaccine confidence in online communities with community-oriented motivational interviewing. He's written about applying models of epidemic disease surveillance and response as a guide to the problem of misinformation, and he served as a consultant to the Office of the Surgeon General on the topic of the impact of COVID-19 misinformation during the pandemic. In his spare time, he enjoys learning and speaking different languages, biking, playing water polo, and reading with his 2-year-old son. All awesome things. So Dr. Scales, David, thank you so much for joining us today. And I'm really looking forward to hearing you shed some light on this conundrum.
Thank you, Wendy. It's an honor to be here. I'm looking forward to talking to you all. This is obviously a very large topic. So I just hope to kind of provide a little bit of a framework and some examples that might assist in some of your thinking as you guys are working with patients and inevitably encountering patients that have perspectives that might be informed by misinformation. So my talk today is called The Toxins We Carry. And I'm going to go into why I specifically talk about, why are we talking about toxins? Tackling medical misinformation beyond COVID-19 vaccine hesitancy. So just to disclose, so I'm a consultant for the Office of the Surgeon General and CMO for Critica, as Wendy mentioned. Critica is an NGO. We're primarily funded through the Robert Wood Johnson Foundation. Just also want to acknowledge the people that I work with. So Jack and Sarah Gorman, who started Critica, Dr. B.K. Titanji, who some of you might know from the Department of Infectious Diseases at Emory. Tyler Starks is a major collaborator at Hunter, our infodemiologists, our collaborator at the Annenberg School of Communication at the University of Pennsylvania, Kathleen Hall-Jameson, and of course our funders, the Robert Wood Johnson Foundation. So what are we going to talk about today? So first, we're going to try to get on the same page about what are we talking about when we talk about misinformation. Then I'm going to try to describe to you how we have moved, how our information ecosystem has moved from the need for traditional types of message-based communication to more networked health communication, and how message-based to environmental models of information health can shape the way that we think about how we can address this problem. And then specifically, how we can operationalize this information environment framework to broadly address medical misinformation, even at the point of care, which I know might sound overwhelming, but I'm hoping by the end of this talk, you might be in agreement with me that we as clinicians have a role to play, even if a lot of the problems in our kind of misinformation, kind of infodemic, as it were, are structural. So to start with, so this is a figure that looks at information disorder on a spectrum from false to kind of things that have an intent to harm. And the spectrum runs from misinformation all the way to disinformation and malinformation. And what determines where you are on that spectrum is often related to the motives behind why someone is repeating or sharing information. So because we often don't know someone's motives, I tend to prefer the term misinformation, which is information that has a false connection or is misleading. Because if we don't know someone's intentions, I can't claim that it's disinformation or malinformation. If you look at the bottom of the screen, you'll see BS, lies, and manipulation essentially as a shorthand way to think about this. If this is something that's interesting to you, I recommend the book On BS, which the actually written out, not just the initials, by Harry Frankfurt, where he defines BS essentially as true or false statements unconnected to a concern for the truth, which I think when we think about how information spreads online, I think that term actually captures a lot of it. So you will hear me use the term misinformation, but please keep in mind that it could also include disinformation or malinformation, depending on the intent of those that are spreading the information. And we've all seen this. I like to point out this article, I Brainwashed Myself with the Internet by Brandy Zadrozny, because, number one, this isn't necessarily all about COVID, and it's not necessarily about internal medicine. There's misinformation of medical consequence in many different topics in every corner of the internet. This is an unfortunate, very unfortunate report that Zadrozny published just before the pandemic. And I like to use this as an example to show that, while a lot of us kind of came to consciousness of this problem and the scale of this problem with the pandemic, this is a problem that predated the pandemic. And my specific trajectory here was when I worked as a reporter, and I started to see reports about things that seemed like misinformation. You guys might have heard about Goop and making unsubstantiated claims about the health impact of its vaginal eggs. You might have read things about Lyme disease. And so in some of the reporting that I did for WBUR, I spent a lot of time in both online and physical communities with people who believe that they are suffering from a manifestation of what they would term as chronic Lyme disease. Talking to providers that provide services along this paradigm and patients who are suffering from symptoms that they attribute to chronic Lyme disease. And the thing that I say about this is it's clear that they're suffering, but it's less clear to me what they're suffering from. And this is a transnational phenomenon. Some of the research that I did in reporting took me to France, where I looked at a similar manifestation of the transnationality of misinformation about Lyme disease and some of the challenges in trying to address this. So my own pathway to misinformation came essentially from that experience, as well as the experiences that I've had as a hospital medicine attending. I had one patient, a 29-year-old woman with Crohn's disease who had anal fistulas, uncontrolled Crohn's, bright red blood per rectum, but multiple admits over a series of months for inability to tolerate PO, while she was refusing biologic therapy and persistently asking for TPN, even though she really didn't meet indications for it because she wasn't really on the fullest extent of her treatment. There was another patient that I had, was a 58-year-old woman who actually had a diagnosis of Ehlers-Danlos. She had actually gone to the farthest reached and gone to Johns Hopkins so she could meet with geneticists who would actually test her for Ehlers-Danlos, and presented with multiple admissions secondary to shortness of breath, acute on chronic lymphedema, and she had diastolic congestive heart failure. The challenge with both of these patients was how they insisted almost every single one of their symptoms was related to the specific disease that they were presenting with. And some of the resistance that I faced as a provider in trying to persuade them to accept standard of care treatments. This is not uncommon. I mean, I think we can see manifestations of medical misinformation even outside of COVID, outside of the pandemic. We see this with The Gospel of Wellness. This is a book by Rena Raphael that was just published in September. We also see this in the phenomenon that social scientists describe as contested illnesses. Now, these are illnesses around which there is a lot of uncertainty. To give an example of contested illnesses, these are things like chronic Lyme disease, as I mentioned, irritable bowel syndrome, inflammatory bowel disease, Ehlers-Danlos, myalgic encephalomyelitis, formerly called chronic fatigue syndrome, Gulf War syndrome, mast cell activation syndrome, and even long COVID. I think as clinicians, we can all think about, we might have in our mind kind of patients that we might have seen with one or more of these illnesses, and found ourselves in some sort of impasse, some sort of disagreement where our perspective on the illness was different than theirs. And the thing that I like to say about this is, like all misinformation, there are kernels of truth. And with almost all of these diseases, there is a degree of scientific consensus. You know, with chronic Lyme disease, there is a discussion about, we all know about Lyme disease itself. There's an increasing recognition of what's called post-treatment Lyme disease syndrome, which has very specific criteria. Long COVID, we're starting to see specific criteria as well. The issue with contested illnesses is that at times, sometimes the illness itself is contested. Whether or not physicians actually believe it exists is in question. But there's usually a kernel of truth where we can agree that there is some sort of disease that exists. But then there's a large penumbra around that consensus where there's a lot of uncertainty. And in this uncertainty, there's advocacy networks of online patient groups that are sharing information and sharing, essentially defining what constitutes the facts for the disease. And I talk about this because my patient with Ehlers-Danlos syndrome had clearly spent a lot of time in these networks and was convinced that pretty much all of her symptoms were related specifically to Ehlers-Danlos syndrome. And the challenge that I had as a physician is I didn't know. There's a lot of uncertainty. A lot of what she was suggesting was in this penumbra of uncertainty. But I'm going to talk a little bit later about how I approach patients like this to try to get to a little bit more of a detente where we can start to move forward, even if we disagree about or feel different degrees of certainty with regard to aspects of their illness. There's a lot of ways where we can find agreement and move forward on a treatment plan. First, let's talk a little bit how we got here and some of the frameworks for how we might address this problem writ large, and then dive into the clinical aspects. So how did we get here? So first is the idea that, as many of you have probably been taught if you've spent time in the laboratory, that good science speaks for itself. Good scientists basically publish their papers and then just let the scientific discussion happen. But in our current information ecosystem, science doesn't speak for itself. Science happens at the speed of a tweet. There's a number of preprints that have gone viral on Twitter. There's a number of aspects where one specific study gets taken out of context or cherry picked and amplified in certain settings and becomes, from the perspective of people that are in certain disease communities, a scientific fact. So this process of how scientific facts become essentially socially mediated to become facts, it has changed in the setting of our current information ecosystem. And I would say science hasn't really caught up with that. This is also amidst an overall media environment where there's declining influence of traditional media structures. This is due to a long history of deregulation, financial crippling of newspapers due to the internet, due to social media, and also declining influence of both television and radio. This is in the context of a rise of these new media structures and various different incentives for engagement. This leads to a situation where there's misinformation, or even positive misinformation, has the potential to spread at unprecedented speed and scale. And for those who are interested, I highly recommend this book, Network Propaganda, by Yochai Benkler and his colleagues. It's about politics, but what I would say is specifically chapter 11 isn't about politics at all. It's about exactly what we're talking about here with regard to the structures that have facilitated in an environment that allows misinformation to spread virally. So what does this look like for health communication? So health communication for a long time has been message-based, where there's a lot of thought and time and energy that goes into crafting the message. That's because scientists are trying to kind of understand what the facts are. They're communicating to scientific advisory panels who are synthesizing some of the data, publishing in scientific journals and preprints. That information gets aggregated by public health practitioners who are trying to decide kind of what public policy should look like based on the science. And we are also doing this as healthcare workers and clinicians. But then some of these messages, they need to get transmitted to the public. So public health practitioners were often in the past leveraging media and journalists. They would do this through relationships they might have had with reporters, through press conferences, and ultimately it would reach the public. But this isn't really how health communication is happening anymore. And we saw this during the pandemic. There's a certain manifestation of networked health communication, where in a lot of environments, online in particular, all of these stakeholders are communicating with each other. Now, to be clear, I'm not trying to argue that message-based communication doesn't exist at all or isn't important, but the relative proportion, the relative importance of message-based communication in the Walter Cronkite era versus now, I think we can all agree that there's been a pretty significant shift in terms of the importance relative to where people are getting a lot of their information of health consequence. So what does this networked health communication mean? So this means that I like the quotation that Young and Miller wrote about here, where they say today's media users experience decentralized, interpersonal, horizontal, networked, politically relevant communication every day. Now, it's decentralized because no one really controls the narrative. It's interpersonal because a lot of this is based on the individual contacts that we have with other people, whether that's someone that we know personally, like our friends and family, or the fact that I can follow LeBron James on Twitter. The influence is not determined by expertise. It's determined essentially by engagement, attention, the number of followers that you might have. This tends to prioritize communications that leverage emotions over rationality. So this also manifests as a horizontal network where it's non-hierarchical. Expertise doesn't matter nearly as much as some of the other factors that we've talked about. This makes information not in this message-based top-down type of structure, but messages travel from one person to the other. It's networked because nested groups of individuals and communities are sharing information, especially those that have shared identities or shared values or some sense of however they define community, rather than some sort of experts bestowing their knowledge upon the public. And it's politically relevant. I think this is really important because, as we talk about health-based information, that's often what social scientists would call an ethic perspective. That's the perspective of outsiders, of people like us as healthcare providers. But from within the communities themselves, kind of what social scientists would call the emic perspective. A lot of times these aren't health issues at all. These are political issues. If we're talking about abortion, if we're talking about vaccination, to a lot of people, that's not a health issue. It's a religious one, it's a values-based one, or it's a political one about their expressions of free speech. And that's an important thing for us to recognize, is even the framing of what types of issues these are. Are these health issues or are these something else, is something that experts don't necessarily have a monopoly on in terms of that framing. So what does this mean practically speaking? So I like to show this network map because this is a specific example. So let's go back. This is California, circa 2015, 2016, and this is a network map of Twitter conversations from people talking about vaccines and a specific state bill 277, that was designed to essentially end personal belief exemptions from vaccination. So what you see here, you see clusters of different, essentially, interest groups talking to each other on Twitter. So the orange group at the bottom, that's autism. These are people who are specifically talking about autism and its relationship to vaccines. And each bubble there represents essentially a Twitter user. That bubble is a node. And the size of that node is the number of followers that they have. And the connections between each node are essentially how often they are speaking to or linking to one another, including both specific connections with they at someone in their tweets, or if they're following. So if orange is autism, we can also see pink is specifically a community focused around anti-vaccine. The blue is the medical freedom community. This is also about the time that there was the Tea Party contingent of political activists was very active, and that's the teal over on the right. And that somewhat tiny community way on the fringe that doesn't really seem to have much connections to anyone else is actually the public health pro-vaccine community. And I like to show this figure because this is the problem that public health has. In communication about information of health consequence is already networked. And yet public health communication, our medical communication of consequence, is not networked. We are still very much in a message-based paradigm that falls victim to the field of dreams fallacy, the idea that if you build it, they will come. But we need to switch our approach to a more networked type of communication. So we've seen this isn't just about vaccines. There's some other papers that look at the network structures, looking at discussions around Ebola, vaccines, but in a slightly different framework in Zika. And I apologize for the quality of these images. The images are of poor quality in the papers themselves, but just describing them briefly, these are essentially maps of the different stakeholders that are having discussions about these issues, with yellow tending to be more mainstream type media, blue tending to be a little bit more kind of user created. Green tends to be essentially very medically oriented, and the orange, sorry, not the orange, the magenta is the public health community. And similar to the previous slide, you can see that the public health discussions are not really integrated into the network, off to the periphery and relatively small compared to the larger discussion at hand. This is, this is challenging. These network maps are trying to capture what I think a lot of people feel when they're in an online space. But I will say, I think that the empirical science behind these network maps still leaves a lot to be desired for us to kind of feel conclusively, rigorous in our conclusions that we can draw from them. But the thing that I do like to say is I think it's pretty clear that public health tends to be on the periphery of these networked discussions. So I've spoken previously about how we can start to see this problem writ large of information of health consequence being spread and affecting people's behaviors and perspectives. This has been described by the World Health Organization as an infodemic, as an overabundance of information. And I've spoken about this previously in an article talking about how we can perceive this as essentially the same mechanisms and the same manifestations as we perceive with infectious diseases. Communicable diseases ultimately communicate. And if we can understand kind of the connections in these metaphors and what type of window this gives us into our response to this, I think that's an important thing that we can take away, because we can do surveillance on misinformation, we can do diagnosis, we can do response, and we can also be working on prevention. So, but I would argue that this model is insufficient because, when we think about our public health, we can think about the fact that, 100, 150 years ago, there were constant epidemics all the time. It took a certain amount of sanitation, it took a certain amount of getting toxins and pathogens under control before we could really start to focus on an outbreak-oriented approach. We first had to start with a sanitary and a hygiene-based approach. So this somewhat environmental thinking is one that I'm not the first one to kind of talk about this metaphor. Whitney Phillips, who's a communications professor at Syracuse University, has written a number of pieces about this, including this piece in Columbia Journalism Review, talking about the toxins we carry. And I think it's an important perspective because it helps us shift from a message-based to an environment-based model of information health. And it also helps us recognize that the goal here is not to completely eradicate kind of our information ecosystem of misinformation. That's impossible, just like it's impossible to eradicate our entire world of toxins. The goal is really to render misinformation as harmless as possible. And there's a lot we can take from an environmental health framework to do that. Now, environmental health frameworks are complicated. So similar to an infectious disease framework, we're not necessarily trying to adapt everything. We're not trying to figure out the R naught of every bit of misinformation. Similarly, there's aspects of environmental health and toxicology that can apply to what we're talking about here, but we're not necessarily going to try to dive in at this level. Let's just step back at kind of a main tenet of toxicology, which is the idea that dose makes the poison. Anyone who's worked as a hospitalist on an internal medicine ward has seen patients who have come in with essentially water toxicity, with hyponatremia. The dose is what makes the poison. Caffeine can be poisonous at certain doses, and sodium fluoroacetate, also known as 1080, which can be a very harmful inhibitor of the Krebs cycle and metabolic components of our body. It requires much less for it to become toxic. And so when we think about toxicology, we can start to think about the factors that are really important. There's individual variability, medical conditions, genetics, age, gender, but there's a number of aspects that go into the dose as well, kind of the duration of exposure, the amount, the concentration, the route. Did we ingest it orally, or was it just on our skin? How much did we absorb? The frequency of exposure when it comes to certain things like aflatoxins, we can think about that as well. All of these things come together and produce toxicity, both at individual and population levels. We can also think about things that are positive, like access to health services, access to a healthy environment, access to geographic locations that help mitigate some of these environmental toxins. And from what we're talking about, access to technology. Because we can think from an environmental health framework, and I like to think about asthma, that we know that there's individual variability in terms of who gets asthma based on genetics, certain medical conditions, or the allostatic load that someone has essentially been immersed in during their life course. There's also kind of the need to minimize toxic exposures, the dose of certain things like pollutants, the duration that people are exposed to them, the frequency, and the toxicity. And then we also know that it's important to maximize exposure to healthy environments, access to healthcare, access to information, access to environments where people can live without asthma triggers. And these are things related to location, like do they have access to green spaces? Do they have the mobility to get there? But also aspects relating to certain social and structural determinants of health to know whether or not people are able to afford things like humidifiers, or do they live in public housing where mold exists and no one's really taking care of a lot of the problems that exist in certain types of housing. So we can adapt this framework towards information environments as well, because there's a lot of psychological literature that's looking at individual predispositions in terms of personality, some of the cultural values that are associated with belief in misinformation. There's a term that I really don't like, but it's common in the literature about cognitive sophistication. There's also just the individual agency that people have in terms of their media consumption habits. We can also minimize toxic exposures. And what does this mean from a misinformation perspective, but how we get in our information? We know that certain types of information are stickier than others, right? If you read something on a CDC website, that takes work. That's harder to remember than if you watch it in a TikTok video. So the dose that's required to remember something, you don't have to read it as many times if you're just watching it as a video versus if you're reading kind of up to date or a CDC website. So the duration, the frequency, and there are certain memes that tend to be more toxic. Our collaborators at Annenberg School of Communication, Kathleen Hall-Jameson, and the factcheck.org group have some preliminary data to suggest that certain memes about the vaccines tend to be more toxic and spread with more frequency and are stickier psychologically. And those include misinformation about the vaccines changing your DNA and your genetic makeup. Those are memes about vaccines affecting fertility. And those are aspects comparing how, claiming falsely that the vaccines are more dangerous than COVID itself. And then finally, we can maximize exposure to healthy information environments. This means access to high quality information, both in trying to help incentivize healthier media consumption habits, but also structural factors to ensure that people have access to these things, to ensure that algorithms are promoting high quality information over the more toxic information. And then this is also an issue of healthcare access, promoting access to healthcare and trusted experts. Survey after survey shows that that people trust their primary care physicians. But if they can't access their primary care physicians, they're getting information from more accessible sources. And this is very important when we start thinking about overall information environments. So when we start to apply this model to things that we can do, we can think about this from a sanitary perspective. There's certain prevention techniques that we can think about that are really important, because as we know, like, we didn't really get kind of epidemics of food safety under control until we made food safer and had a lot more regulations around food, until we kind of started working on making sure our water was clean, taking off the pump handle as Jon Snow is famous for, and then also, you know, including antibiotics and vaccines. Then we started to be able to work towards an epidemic focused model, rather than everything seeming like a constant epidemic, which is a little bit what it feels like now if you're working in the misinformation space. So this means doing things like trying to reduce kind of algorithmic approaches that help people brainwash themselves with the internet, trying to avoid epistemic bubbles and echo chambers. This also means building media literacy and digital literacy so that people can use these tools, but not necessarily be sucked down rabbit holes that make you start to believe that the earth is flat. This is also a particular focus on marginalized populations who have very real and historic reasons to mistrust the government or mistrust kind of common sources of trusted information, and try to make sure that that distrust cannot be leveraged to further sow distrust. An excellent example of this is the Nation of Islam, who is very stridently anti-vaccine and has done a lot of work, even partnering with Children's Health Defense to create anti-vaccine materials specifically targeting Black communities in the United States on the basis of very real medical mistrust from a long history of racial discrimination. So there's a lot that we can do on this front as well. And then finally, ultimately, there needs to be a lot of content moderation. This is going to be an essential component going forward. Some of this has started to happen already, where the National Academy of Medicine has come out with a report identifying credible sources of health information on digital platforms and has developed some principles. And these principles are actually being incorporated into algorithms on YouTube so that it prioritizes information coming from the most credible sources. This is a start. I would say this is necessary, but very likely insufficient to start to get our hand around this problem. But as with any kind of environmental approach, we're going to need a conglomerate, just a piecemeal approach, attacking this from a number of different angles. There's also aspects on the response side. And what I mean by that is trying to maximize exposure to healthy information. This is a little bit of some of the work that we do with our infodemiologists. There's also an argument that I make for screening for information environments at the point of care, like we do for other social determinants of health. And then briefly, I'll go into a little bit of a discussion of, some things that we can do as clinicians. What are some of the response strategies that we can have? And obviously, I'm not going to be able to go into that into too much depth, but hopefully just to cover briefly that here. So I mentioned earlier about how networked health communication puts all the stakeholders in the same room. This can lead to a lot of miscommunication and misunderstanding, because a word used in one environment, a word like septic, for example, means something else in amongst other communities. And I think we saw this with the pandemic when people were talking about Omicron being mild. And it was arguably mild from an epidemiological population health perspective. But then people interpreted that as, well, it's going to be mild if an individual gets hit. And that was clearly not necessarily the case. Our infodemiologists, we see them as working in this space. And our infodemiologists, we see essentially as the field epidemiologists for infodemic response, where they are engaging kind of as part of their time being kind of community embedded, working in online communities as liaisons between experts who have the information and their community. They are doing community-oriented motivational interviewing, which is an adaptation of motivational interviewing that we are engaging in to adapt it to these online community spaces. Because motivational interviewing, there's a lot of empirical research showing that this is often some of the best ways to engage people to understand where they are on the spectrum of behavior change. And if they are in a stage where you can engage them, then working with them to understand kind of the barriers to resistance. We also argue that infodemiologists are probably going to be most effective if they have a network where they can share information with other infodemiologists about what misinformation is circulating in their communities, so they can share kind of effective responses to it, and also share it up the hierarchy within the public health community so that people higher up the chain kind of can leverage resources necessary to try to help tamp down on epidemics of misinformation that seem to be essentially going viral. So who could be an infodemiologist? We argue essentially any healthcare worker could, community health workers, GPs, NPs, public health department officials, specialist societies. We've been working with the American Physical Society, and we've been working with the American Board of Internal Medicine as well. Trusted community leaders, and potentially someone like you. So if this would be interesting to you, please don't hesitate to get in touch. We see our infodemiologists essentially as mediators in this networked communication space, translators, ambassadors. Kind of there's a number of different ways that you can think about the work that they do, but essentially trying to help make sure that these conversations in these chambers where everyone is talking to each other, to help make sure that misunderstandings don't happen nearly as frequently. So we also make the argument that it's important to screen for information environments at the point of care. So these include questions like, where do you get your health information? So the patient I had with Ehlers-Danlos syndrome, this is a question I put to her specifically. And she walked me through kind of where she got a lot of her health information. And it revealed that she was getting a lot of her health information from people that she thought very highly of because they had won this award or that award or worked at some famous medical center. And what I did is I walked her through kind of some of their profiles on quackwatch.com to show her that I understand that you see these are trusted sources, but I'm worried that some of the information they are promulgating might not actually be in your best interests. So we can ask questions about, where do you get your health information? How do you decide what or who is trustworthy? How do you sort between good and bad information? We as physicians, we don't just have knowledge, right? Because people can get knowledge from Google. What we have is we have a framework for making kind of clinical decisions. And our clinical decision-making framework of pre-test probability, likelihood ratio, and post-test probability is something that in the work that I've done with communities that are suffering from contested illnesses, this is often one of the biggest misunderstandings that I find, is that there's a certain illusory truth effect by hearing things over and over and over in the epistemic bubbles that they are sometimes existing in these disease communities where they are sharing a lot of this information. And it just gets absorbed. It's not necessarily a conscious process of, I'm now going to believe this information. But this is something that we as physicians try to be very careful about, to decide between a good and a bad paper that is published in a medical journal. That's something that we're trained to do. And this is something that we can have conversations with our patients, not necessarily to go in depth on kind of, journal review or inviting them to journal clubs, but just to help them understand that there is a difference between a good or a bad paper. And that's an important aspect of information literacy and science literacy. So the goal ultimately in some of these conversations is to understand someone's individual predisposition, their exposure to toxic information, and their access to high quality health information. And I do make the case, this is not something that every provider needs to do with every patient. Just like, if you're working as a provider in a primary care clinic, you might not necessarily have the time to ask someone about their alcohol content, but the people that you're working with, the nurse or the MA might screen for that and let you know when it turns out your patient who you might not have suspected is drinking 30 to 40 beers a week. That's the kind of thing that you would want to know, and then you put it on your list as something to intervene in. This is also something that we can start to do at the point of care, and I talk a little bit more about this in this commentary. So what are some of the techniques that you can use for communicating on contentious issues? Because I think this is something that is worrisome for providers. So first, the evidence for motivational interviewing is very strong. the empirical evidence is primarily in the vaccine hesitancy space, but there's starting to be more and more empirical papers to study this in other contexts related to misinformation. There's also the argument that we should acknowledge complexity and nuance. That's usually something that our patients understand too. And we can retain trust even about extremely contentious political issues by emphasizing our role as a clinician, trying to work with the patient to figure out what's best for them in their unique circumstances. This is what helps us leverage the trust that people have in their providers. And for more work on this, you can read some of the work that's done by Arnaud Gagnard at the University of Sherbrooke. He's done a lot of work on motivational interviewing and vaccine hesitancy. And Lisa Martin, who's an OBGYN at Michigan, who's done a lot of work, not all of it published, but a lot of work looking at how providers can talk about the contentious issue of abortion, even in situations where it seems highly polarized. So one other approach that the World Health Organization has advocated is specifically trying to understand some of the structures that people use in science denial techniques. And patients that come into our clinics, I think often not necessarily because they are science denialists, but because they are in circles where they're reading information online, getting information from what might be dubious sources. There's a certain amount of adoption of some of these techniques. And so we hear them in the clinic and in clinical settings, even if people don't necessarily recognize that these are common anti-science tropes. But we can start to hear them because, people say things like, I prefer natural products, or pharma's just out to make money. Monkeypox isn't a big deal. Sometimes people say that, or, I heard that diabetes, it's more, the medications are more dangerous than the disease. Medications don't work for me. Government just wants to control you. People get horrible side effects. Gates is trying to track you. And we can put these into categories where people are often worried about some larger picture. Maybe it's the threat of disease. Maybe it's the idea that there might be alternatives, trust, the effectiveness of certain things, and safety. And we can put these concerns that they have in these larger bucket categories and try to address those specific categories. But first, we also need to identify the technique in which they're saying these concerns. These can be things like conspiracy theories. Sometimes there's selectivity, cherry picking certain papers that kind of lean them towards a specific perspective. Fake experts. This is something that we often find in the anti-vaccine space. With Wakefield is probably the best example. Then there's also misrepresentation and false logic. This is where our role as physicians can help in the way that we think through clinical decision-making. We can walk people through our thinking and see that there's a certain amount of false logic. There's also sometimes impossible expectations. We've seen this a lot with the vaccines, where people talk about, oh, the vaccines don't work, where the expectation was that the vaccines were going to stop COVID in its tracks and COVID wasn't going to be an issue anymore. And it's like, well, they've saved many, many, many lives. Just because they're not super effective at blocking all transmission does not necessarily mean that they have failed. So if we choose a response to the technique and we choose a response to the topic, this helps us design our answer. Now, there's a lot more on this. This is just a very broad overview of some of the tricks and techniques that you can use in clinical settings. More of this has gone into kind of in the report that the World Health Organization wrote from their European office on best practice guidance on responding to vocal vaccine deniers in public. We have found this to be helpful, not just for vocal vaccine deniers in public, but often in discussing misinformation in general, even about other topics that have no relationship to vaccine, and even in one-on-one conversations. So just to recap, our goal today was to define misinformation, was to talk about how we can move from message-based to networked health communication, and how this requires moving from message-based to environmental models of information health, and how ultimately I think this can help us operationalize an information environment framework to broadly address medical misinformation at the point of care. And with that, I've put my email address on screen. I'd be more than happy to continue this discussion with folks that want to get in touch. And I look forward to your questions.
Great, thank you so much. And everybody feel free to put questions in the chat or raise your hand if you wish. Dr. Del Rio, I see your hand raised. Go ahead and unmute.
Yeah, thank you, David. That was great. I mean, my only question to you is, you know, your premise is almost like we physicians are not spreading misinformation. We're just a solution, when in fact we're frequently, I mean, there's a group of physicians, not many, but they're out there who are actually spreading misinformation and who are the ones that are fueling this. And many of them have been, you know, they've been sanctioned by their boards. The ABIM is looking into what else to do. But I think we need to talk about how to deal with colleagues that are spreading misinformation and what's the best approach there.
I completely agree. I know the American Board of Internal Medicine and a number of other medical specialties have been talking about essentially revoking diplomats from very egregious spreaders of misinformation. So that's one thing that's been talked about. There's a piece that I'm working on trying to publish right now that is talking about kind of, when I mentioned how we got here, there's a certain sociological aspect of how scientific facts are created, and that tends to be a socially mediated process. I think one of the things that we're finding is a lot of physicians are engaging in debates and discussion on social media that are completely legitimate scientific debates. But the problem is those debates, because they're happening in public, can very easily get co-opted by political actors. And I think one of the things that we need to do as a profession is recognize when the debate that we're having is happening in public, because that is not necessarily something like, while debate is super important for science, having a debate in public about scientific topics that are extremely uncertain and highly politicized does not necessarily lead to increased trust in science. And I would argue tends to increase misunderstandings and misinformation, and is very easy for a scientist that's just trying to have a scientific debate, to be co-opted by political actors.
I agree 100%. Thank you.
No, agree as well. Communicating nuance is something that I think that's really difficult for the public to understand often, at least seeing this in my own family. Dr. Law.
Yeah, thank you, Wendy, and thank you, Carlos. I think you guys set me up well for my question. David, thanks for being here. You know, as physicians and scientists, there will always be uncertainty. And I find that many times the areas not only of nuance, but especially uncertainty, are the places where misinformation really takes hold. Autism is a great example where I think families are looking for answers about what caused this problem. And I think we in the scientific community can't answer that yet. Similarly, in the early phases of the pandemic, there was so much unknown and uncertainty that we as a scientific community didn't have scientific answers to. And that then leads to that offers the opportunity for misinformation to really take hold. So I'd love for you to speak a little bit, if you could, on how you might recommend that we discuss the concept of uncertainty with patients, perhaps in a way to help build relationships where we can continue to have conversations about misinformation.
Thanks for that question. This is a topic that I love to talk about, because I think this is a crucial factor that is not always addressed when we're thinking about why misinformation spreads and what we need to do to counteract it. The sociological literature on this is mixed. There's a lot of different factions on this. Briefly, I'll just tell you about one. So Hofstede, he was a sociologist in the 60s that looked at business cultures at IBM. And he kind of separated cultural values that came out of the hundreds, almost 100,000 surveys that he did across 50 different countries to separate out different cultural values. These are things like power distance, how important are hierarchies, uncertainty avoidance, which we can think of essentially as a tolerance for ambiguity, and other aspects, some of which sound really dated. He talked about like masculinity, femininity, which sound weird to us now, but you could essentially think of as a little bit of a, you know, stiff upper lip culture versus a nurturing culture. And there's a number of others. There's a lot of other kind of cultural frameworks. Schwartz has one. There's a lot of other people that have different frameworks. But I like Hofstede's because the uncertainty avoidance and power distance have come up in a lot of medical studies. So mostly in Europe, though. And this has actually been shown to be extremely important when it comes to antibiotic decision-making, because based on surveys that they've been doing for well over 20 years, countries that have high rates of uncertainty avoidance and high power distance have higher rates of antibiotic prescribing, antibiotic seeking behavior by patients, and antibiotic resistance. And the scary thing is this stuff is deep. It generally kind of tracks along the Protestant Catholic line between Northern Europe being a lot more comfortable with uncertainty and having flatter hierarchies, and Southern Europe having much more power distance, kind of more rigid hierarchies, and much less tolerance of uncertainty. Now, the challenge with this is if you're doing any sort of behavior change modification around antibiotic prescribing, you need to be taking these cultural factors into account. There's also been some fantastic work that looks at these cultural differences between medical specialties, looking at how surgery tends to be on the spectrum of uncertainty avoidant, and so tends to not follow antibiotic guidelines on the perspective of both the uncertainty avoidance and the relatively rigid power hierarchies within surgery. Asmita Sharani is a woman who has written about these, and I put her name in the chat. She's at University College London. So there's been a lot more social science work on this, specifically at the intersection of antibiotic prescribing. But I think we can extrapolate to see that this is a larger problem in medicine in general, and it's a cultural one. And so it's not necessarily the easiest to address. One of the things that I try to do is in situations where I recognize there might be some uncertainty differences in terms of uncertainty tolerance between my tolerance for uncertainty and my patient's tolerance for uncertainty, I usually try to find some way to offer certainty, even if that's certainty of process, where someone walks into a clinic with saying that they have Lyme disease, and they're coming with a 3-inch binder of all the tests that they've had previously, and a lot of clear anxiety about their disease. I try to be careful to not dismiss them as just being anxious or kind of having medically unexplained symptoms, but they're kind of can't be reassured. There's a lot of pejorative terms that are in the medical literature for this type of, essentially what I would argue is a discrepancy between the physician's tolerance for uncertainty and the patient's tolerance for uncertainty. And then I start to work with them to try to essentially walk them through what I'm going to do to make sure that I look under every stone, and I'm going to know your chart better than anybody else. And that doesn't mean that I'm going to find an answer, but it does mean that we're going to talk to everyone that we need to talk to try to get as close to an answer as we can. In some situations, patients find that comforting. In other situations, not having that diagnosis is still very discomforting for patients. And that's something that we can work with, but at least we've done what we could to try to find as much certainty as possible.
Yeah, thanks. I think that term certainty of process is helpful. And I think we've definitely all seen that, at least if we can't provide the scientific answer, a certainty of process and building trust through that is one avenue to pursue. Yeah, thank you so much.
There are several great questions in the chat that we won't have time to get to all of. So this is going to be sort of the rapid fire round. Our residents are asking a couple of things. Do you have any guidance? You talked really about the infodemiologists being what I think of as trusted messengers. Do you have guidance though on how to approach medical mistrust from marginalized groups when you're at the bedside? You don't have that community person that is there to sort of help you. And also from them, so not only at the bedside, but then how about with open notes and the communication of uncertainty there?
Sure, thanks. I'll actually start with the open notes question, because the short answer that I would say is I don't know how this is going to affect. What I would say is, Facebook instituted its share button in about 2011, 2012, and that turned information consumers into information producers, right? And we only started to see the knock-on effects of that well after that. Twitter introduced its retweet button around the same time, so it completely changed the network architecture of how information was transmitted. what we've seen is open notes is relatively new. What impact this is going to have, I can't be certain, but I'm concerned because it's changing the network architecture of how information is transmitted. And so I think we have yet to see the full impact of what open notes is going to be doing. On the question of how we can kind of engage, it's a lot of the work that I've done with Muslim communities. Before the pandemic hit, I did a lot of global health work, a lot of work with refugees, and a lot of that work, when I would be working with Muslim communities and found myself at an impasse, I would often ask directly. I would say, is there someone that you trust, that you talk to about some of the medical decisions that you make? Sometimes that was another family member, sometimes that was an imam. And I would say, would it be possible to bring them into this conversation? And usually I find that a very helpful place to go. It's not always possible. It depends on kind of the level of trust that you have kind of at that time. This is something that's definitely easier if you have an ongoing relationship with a patient than as a hospitalist. But it's something that I try to ask that question directly and acknowledge the fact that like they have reasons not to trust me. They just met me. But let's try to have a conversation and bring the people who influence you into the room so we can at least kind of put all of our information on the table and try to discuss how we're going to make this decision. Is this going to be a values-based decision? Is this going to be essentially an identity-based one? Or is this one that we're going to make with the best evidence that we have available? Because that's my job. I can bring the evidence to bear, but sometimes you need the values person in the room.
That's a really nice thought. We are at the top of the hour, and so I think we have to close. Sorry, Doctors Dressler and Henry, who also had fantastic questions in the chat. But thank you so much, Dr. Scales. This was a really interesting sort of dive into thinking about this problem of misinformation. I'm afraid we'll never get the genie back in the bottle, but it at least gave us some ways to think about moving forward.
Thanks again for having me. It was a pleasure to be here. Please don't hesitate to get in touch if you have any questions.
Great, thank you.